Volume of distribution. This is a very fun one. What is the volume of distribution? Let's go to the question. So the question comes like this. Define volume of distribution. What are the factors that what factors influence the size of volume of distribution? How can we calculate, and what assumptions are used in this calculation? So the question lends itself to a structure. Define volume of distribution. What are the factors? And then we can talk about the assumptions and calculations. So define it. What is give me a definition right now. What is it? The apparent volume that is dispersed in the drug that determines or doesn't determine. Sorry, that I guess correlates to the plasma concentration, or that dispersed into to achieve the observed plasma concentration. It's a theoretical volume that does not correspond to the physical volume, and hence it can be greater than the total body weight. Used to calculate also the loading dose to reach steady state. What are the factors that affect it? So we have drug factors that affect it, which is Fick's law. Concentration gradient, increase lipid solubility, percentage unionized, protein binding. So with protein binding, it can be a bit complex. Reduced protein binding will increase the percent of the unbound drug, and so that will increase volume of distribution. Yes, increase volume of distribution. Sorry. Decreasing, let's figure this out. Decreasing protein binding will increase the percent of unbound drug, correct? So there will be increased volume of distribution. Increased protein binding will decrease the percent of unbound, this is for tissue, and will therefore decrease. I feel like that's decreased protein. If there's less protein binding, oh, they both increase actually, because the one is sorry, I've stuffed up. So increased protein binding in the tissue will cause an increase in the tissue, so you have more volume of distribution. And then decreasing the protein binding will mean more. So they both obviously go up, but that one is down in that. So this is plasma and this is tissue. Decreased molecular weight and thickness will reduce, and that will cause greater distribution, greater volume. Patient factors. This is really good. Age, gender, obesity. So the way you can remember this is special populations, basically. So neonates, what do they have? Increased total body water, so increased volume distribution for hypophilic drugs. Pregnancy, what do you have? Increased fat, but you also have increased total body water. Elderly, you have decreased total water, you have increased fat, you have decreased muscle, so decreased VD. Gender, males have more total body water, females have more fat. Obesity, high lean body mass plus fat. Increased VD for water and lipid soluble drugs. Cardiac output. Cardiac output is a good one. So when you increase cardiac output, so you have a lot of volume, a lot of cardiac output here, right? It's like full to the brim. What are you going to have when you have the injection? You're going to have a diluted, so you don't have increased peak plasma, but you have a faster onset because it moves quicker. So quicker time to peak effect. Okay, so quicker, faster onset, then more greater VD, but you have a lower peak concentration. And then pathology stuff, so renal, hepatic, cardiac, fluid overload increases VD. Hypovolemic shock decreases VD. We kind of talked about that with a decreased cardiac output. Then how do you calculate loading dose? So loading dose, we know the equation VD is loading dose over CP. But what does this assume? It's a single compartment. There's nothing here, VDSS, nothing, right? So single compartment is 100% bioavailability and no metabolism at the time of blood sampling. For multi-compartment model, if VDSS is used, then you overdose, right? You risk of toxicity because you overshoot. If VD compartment is used, so you're only using basically the VD, then you underdose when you calculate the loading dose.